Good morning. Today I'm presenting original research titled Coronavirus Disease 2019 and the Risk of Hypertensive Disorders of Pregnancy, a retrospective cohort study. To give a little background, there were a small number of cases of COVID-19 in pregnancy across several Ascension, Michigan hospitals starting in March of 2020. Approximately 30% of these patients developed a hypertensive disorder of pregnancy, namely preeclampsia or preeclampsia with severe features. This incidence was much higher than the 6 to 11% baseline incidence for hypertensive disorders of pregnancy. This is important because we know that patients diagnosed with a hypertensive disorder of pregnancy are at an increased risk of iatrogenic preterm births, as many of these patients wind up being induced early. Thus, if COVID-19 increased the risk of hypertensive disorders of pregnancy, we would expect to see an increase in iatrogenic preterm deliveries. COVID-19 is now ubiquitous, with nearly everyone affected in some way. Therefore, I will only provide a brief background. In December of 2019, there was a report from Wuhan, Hubei province of China, about a cluster of cases of severe pneumonia. These cases were thought to be linked to the Hunan seafood wholesale market. By early January, Chinese health authorities confirmed that the outbreak was caused by a novel coronavirus. This novel coronavirus was subsequently named Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. Early but limited reports suggested an association between COVID-19 and pregnancy and the subsequent development of gestational hypertension, preeclampsia, and/or HELLP syndrome. However, these reports were mainly confined to case series or systematic reviews that incorporated multiple species of coronavirus, namely SARS-CoV-1 and MERS-CoV. Other systematic reviews did not include pregnant patients or did not examine the association of SARS-CoV-2 infection with hypertensive disorders of pregnancy. The few studies that did assess this association lacked a comparator group, were underpowered or were based on composite indices, thus limiting the interpretation of the results. Therefore, we set out to see if there was an association between SARS-CoV-2 infection and hypertensive disorders in pregnancy. We conducted a historical cohort study that compared index deliveries, which were defined as pregnancies affected by COVID-19, to the 3 subsequent deliveries that did not have a COVID-19 diagnosis during their pregnancy. Our study included 3 community hospitals in the Metro Detroit area, and we collected data from February 1st, 2020 through November 24th, 2020. All undelivered patients were excluded. We had estimated that the incidence of a hypertensive disorder of pregnancy would be about 6.5% in pregnancies that were not affected by COVID-19. And then based on limited reports, we estimated that this number would jump to approximately 16.5% of patients who were diagnosed with COVID-19 during their pregnancy. To detect this difference, we, with an 80% power and an alpha error rate of 0.05, we would need 360 participants with a 3-to-1 ratio of controls to index cases. We used students' t-test, chi-squared analysis, and ANOVA to conduct a univariable analysis. We use logistic regression for multivariable analysis. All variables associated with a hypertensive disorder of pregnancy or a COVID-19 diagnosis with a p-value of less than 0.1 was entered into our multivariable logistic regression with a forward likelihood ratio algorithm. The model with the lowest -2 log likelihood value was taken to be the best model for our data, and a p-value of less than 0.05 was taken to indicate statistical significance. During our study period, there were 5,962 deliveries at the participating institutions. Of those deliveries, 70 patients tested positive for COVID-19. Those 70 patients were matched to the subsequent 3 deliveries, resulting in 210 additional patients, for a total of 280 deliveries analyzed. Of the 70 patients that tested positive for COVID-19 during their pregnancy, 22 were diagnosed with a hypertensive disorder of pregnancy. Of the 210 deliveries that did not have a COVID-19 diagnosis during their pregnancy, 28 received a diagnosis of a hypertensive disorder of pregnancy. With regards to demographics, we found that Black patients were much more likely to be diagnosed with COVID-19 during their pregnancy. Those that used recreational drugs had a higher likelihood of having a COVID-19 diagnosis during their pregnancy. And those that had COVID-19 during their pregnancy were found to deliver at a earlier gestational age compared to those that were COVID-19 negative during their pregnancy. We conducted a chi-square analysis for our primary outcome and found that approximately 31% of patients with COVID-19 during their pregnancy had a hypertensive disorder of pregnancy diagnosis, while only 13% of patients without COVID had a similar diagnosis. And this was statistically significant with a p-value of 0.01. We ran a univariable analysis, and we found that COVID-19, preeclampsia in a previous pregnancy, current chronic hypertension, asthma, and a higher BMI were all associated with a hypertensive disorder of pregnancy. To evaluate for confounding, we conducted a logistic regression analysis and found that patients with COVID-19 in pregnancy were approximately 3.7 times more likely to develop a hypertensive disorder compared with those that tested negative, even after controlling for other predictors. Interestingly, a history of prior cesarean section appeared to be protective. When we look at it graphically on a forest plot, we see that chronic hypertension and preeclampsia in a previous pregnancy were the strongest predictors of hypertensive disorders of pregnancy, with COVID-19 being the third strongest predictor. When we look at all patients, we see that patients diagnosed with COVID-19 in their pregnancy had a higher risk of gestational hypertension, which is represented by the green bars, preeclampsia, which is represented by the blue bars, and preeclampsia with severe features, which is represented by the yellow bars. When we stratified patients with a COVID-19 diagnosis by symptomatology, we found that the majority of patients with a concomitant diagnosis of a hypertensive disorder of pregnancy were actually asymptomatic from a COVID standpoint. We also stratified patients by early versus late COVID-19 diagnoses. We defined early COVID-19 as a diagnosis prior to 32 weeks gestation, and late COVID-19 as a diagnosis 32 weeks of gestation or after. We found that those with early COVID were 13 times more likely to be diagnosed with a hypertensive disorder of pregnancy, and this was statistically significant. Those with late COVID were only 1.9 times more likely to develop a hypertensive disorder of pregnancy compared to those without COVID, and this was not statistically significant. Finally, when we compared an early COVID diagnosis versus a late COVID diagnosis, we found that patients with an early COVID diagnosis were 6.8 times more likely to have a hypertensive disorder of pregnancy diagnosis during their pregnancy, and this was highly statistically significant. So we concluded that patients with a history of COVID-19 in pregnancy are at an increased risk of developing a hypertensive disorder of pregnancy, regardless of their symptomatology. COVID-19 in early pregnancy seems to confer a higher risk of a hypertensive disorder in pregnancy compared to being diagnosed with COVID later in pregnancy. This risk is especially true for those that were diagnosed prior to 32 weeks gestation. And then COVID-19 increases the risk of an iatrogenic preterm birth, mainly because those with a hypertensive disorder of pregnancy tend to be delivered early through induction of labor. And this is important because we should develop strategies to mitigate iatrogenic complications related to hypertensive disorders in pregnancy for patients that are diagnosed with COVID-19. For a full copy of the manuscript, including supplemental tables, disease severity, neonatal outcomes, and laboratory markers, please see our publication in Hypertension and Pregnancy, Volume 40, Issue 3, published in September of 2021. I hope you enjoyed this presentation.